in the Infant Well-Child Visit Learning Collaborative Series titled Improving Quality and Utilization of Infant Well-Child Visits. Before we begin, I want to cover a few housekeeping items. Next slide, please. All participants logged into this webinar have been muted for the best sound quality possible. We welcome audience questions throughout today's webinar through the Q&A window located at the bottom right corner of your screen. To send a question or comment related to the webinar, please highlight all panelists and click send in the Ask drop-down list. We will address as many questions as possible during today's webinar. If you have any technical issues, please also use the Q&A window. Please select Host in the Ask drop-down menu and then describe your technical question or issue. I also want to let everyone know that this webinar is being recorded. On the next slide, you'll see that the recording, slides, and transcript from the webinar will be posted on the Medicaid.gov Infant Well-Child Visit landing page. The link is on the slide here, and we will also share it for you through the chat. On the next slide, I'll review our webinar agenda. So we'll begin our webinar today with some welcoming remarks and an overview of our objectives from Deirdre Stockman at CMS. From there, my colleague at Mathematica, Jody Anthony, will provide an overview of the Maternal and Infant Health Initiative. You will then hear from Glory Dole, the Compliance Section Manager in the Medicaid Programs Division in the state of Washington, and she'll be followed by Dr. William Golden, the Medical Director for Arkansas Medicaid. Jody will then facilitate a Q&A discussion, and I will wrap up the webinar with some announcements and next steps. So now I'll turn it over to Deirdre for the welcoming remarks.
Thank you so much, Alyssa, and hello, everyone. My name is Deirdre Stockman. I'm the Acting Deputy Director of the Division of Quality and Health Outcomes at the Center for Medicaid and CHIP Services at CMS. I'm very pleased to welcome all of you to the second webinar in our Infant Well-Child Learning Collaborative series. This learning collaborative is one of our several quality improvement initiatives at the Center for Medicaid and CHIP Services. And the goal of all of our quality improvement work is to support state Medicaid and CHIP agencies and their partners, including other state agencies, health plans, providers, and advocates, to drive measurable improvement in quality of care and health outcomes for Medicaid and CHIP beneficiaries. Next slide, please. The goal of the Infant Well-Child Visit Learning Collaborative is to help states improve the rate or utilization and quality of well-child visits for infants. As you all know, the first year of a baby's life is a critical time to engage families in care and to assess and address the health needs of some of our youngest beneficiaries. So the purpose of today's webinar is to offer considerations and strategies for improving the use and quality of infant well-child care in different delivery systems. Today, we'll hear about effective approaches both in a managed care environment and in a fee-for-service patient-centered medical home model. While the delivery systems differ, you'll see that each state Medicaid agency was able to effect improvements in infant well-child visit quality and use. So we hope that their experiences they'll share today will provide some tangible steps that other states can adapt in your own unique delivery systems. So with that, I'll turn it over to Jody.
Thanks, Deirdre. Next slide, please. So I'll also offer my welcome and welcome back to those who joined the first webinar in the series. And I just want to tell you a little bit more about the collaborative. It is one of 3 focus areas that CMS is undertaking as part of its Maternal and Infant Health Initiative. This initiative is a multi-year one informed by an expert work group. So I recognize that this figure is a little busy, but it demonstrates the initiative's framework, and I'd like to highlight a few important elements. First, the expert work group emphasized the need for a comprehensive life course approach to maternal and infant health, one that recognizes the importance of the mother-infant dyad, as well as the interconnectedness of the focus areas and how they affect both maternal health outcomes throughout the childbearing years, as well as infant and early childhood outcomes. Next slide, please. The second element I would like to highlight are the focus areas on the left-hand side. This Infant Well-Child Collaborative focuses on strategies to increase use and quality of well-child visits, indicated by the red star. In addition, we've already begun a collaborative for the middle focus area, strategies to increase use and quality of postpartum care. And in about 6 months, we'll begin a third collaborative to address the focus area at the top, strategies to decrease cesarean births for women with low-risk pregnancies. Next slide. The third element I'd like to emphasize is the section on infant and maternal outcomes for this collaborative. Research has demonstrated that by increasing use and quality of well-child care, there's an increase in immunizations, breastfeeding, parental knowledge on injury prevention, and fewer injury-related emergency department visits. And there are benefits for the parent too, such as screening for depression and the social determinants of health. Next slide. So how can Medicaid agencies support the use and quality of infant well-child visits? Our team assessed the Peer and Gray literature, combed state websites, and spoke with several states. From this process, we identified high-leverage strategies that state Medicaid agencies and their partners can employ, including aligning payment to support high-quality well-child visits and reduce disparities, using data to drive improvements, cultivating cross-sector provider and beneficiary partnerships, and leveraging quality improvement tools. Today, you'll learn about patient-centered medical home models of care, value-based payment strategies, how data were used to drive improvements, and the critical partnerships, including with families, that informed quality initiatives. Next slide. And just as a reminder, this learning collaborative includes a webinar series open to everyone that provides examples of these strategies in state settings. And then in September, we begin the action-oriented affinity group, where state Medicaid agencies can build, test, and scale these strategies for their unique environments. In the first webinar in the series, we heard from Medicaid colleagues in Texas and Pennsylvania who described their use of managed care contract requirements and incentives, data monitoring, and performance improvement projects. And in addition to today's webinar, I just want to give a plug for the third webinar where representatives from North Carolina, Michigan, and Oregon will describe their models of care and partnerships, including pediatric medical homes, home visiting, and partnering with Title V. And so with that, I will hand it over to Glory Dole. Next slide.
Great, thank you. Thank you for having me here today. My name is Glory Dole, and I'm a nurse, and I'm the Compliance Section Manager at the Washington State Healthcare Authority. My team focuses on Medicaid managed care. We ensure that the managed care organizations, the MCOs, are compliant with the contracts that they have with the Healthcare Authority to deliver Medicaid services. Today, I'm going to discuss some of the strategies the Washington State Healthcare Authority uses to improve infant and child health. I'll discuss strategies the Healthcare Authority is focused on specifically with our state's Medicaid MCOs. I also want to be sure to give credit to my team, and particularly Teresa Cooper, who's here today. She's our subject matter expert in this area. She's been working for years to improve infant and child health across our state, and I wanted to make sure I recognized her. Next slide, please. In this presentation, I'm going to tell you about the Healthcare Authority, HCA, Washington Apple Health, value-based purchasing, performance improvement projects, and the collaborative PIP for the well-child visit measure. Next. About HCA briefly, the Healthcare Authority is the largest healthcare purchaser in Washington State. We purchase healthcare for more than 2.5 million Washingtonians, and that includes Medicaid, public employees, and school employees. Next. A closer look at Washington Apple Health. There are over 2 million Medicaid enrollees. The vast majority, 85%, are in managed care. We contract with 5 MCOs across the state. We also integrated physical and behavioral health. And with the expansion of the Affordable Care Act in 2014, we added more than 650,000 newly eligible adults by the end of 2020. So that's a glimpse of Washington Apple Health. Next slide. VBP, value-based purchasing. The Healthcare Authority implemented VBP to incentivize health plans to purchase healthcare in a different way, using value-based payments to providers. This is a strategy used to basically improve the quality and value of healthcare services that a person receives. VBP ensures health plans and healthcare providers are accountable for providing high quality, high value care and a satisfying patient experience. VBP rewards providers for the quality of healthcare rather than just the volume of patients that they see. This is a difference than paying a set amount of dollars for a specific service. Next. Each year, the Healthcare Authority reviews VBP quality measures that the agency is focused on improving. Here's the list of measures that were selected to impact infant and child health in 2020. Prenatal care, postpartum care, well-child visits, and children's access to primary care. In 2021, we added the measure prenatal and postpartum care, PPC. So that's an overview of the measures that we look at next. Another strategy to improve infant health is through performance improvement projects, or PIPs. For years, Healthcare Authority has been focusing on improving infant and child health through managed care strategies. Looking back to 2015, the Healthcare Authority explored ways to improve immunization and well-child visit rates and focused on PIP requirements. To do that, the Healthcare Authority required additional PIPs for rates below the national 75th percentile for well-child visits or childhood immunization performance measures. The result is that a variety of PIPs across our state were developed by the MCOs, and there was a varying level of success. Next. Due to continued low statewide performance and well-child visit rates, the Healthcare Authority decided to make a coordinated statewide effort. In 2018, the Collaborative Well-Child PIP replaced the individual MCO PIPs. All 5 MCOs are required to participate in this collaborative PIP. The Department of Health is contracted to facilitate the group, and the collaborative PIP actually continues today. We've seen a lot of positive impact on measures. Next. You can see here the significant measure improvement in childhood immunizations, the status combo 2 specifically on this screen, since the PIPs requirement started, with a notable improvement after the statewide collaborative effort began. Next slide. With the combo 10 immunization, you see improvement as well, particularly with the when the statewide collaborative began. Next. Compared to national Medicaid percentages, well-child visits in the first 15 months of life is performing above the 50th percentile, and it remains stable. This continues to be an important area to prioritize. Next. The Collaborative PIP Work Group has shown a lot of success, and I want to walk you through some of the interventions and the pilot projects that we've done. Next. First pilot, the MCOs partnered with clinics. The MCOs chose clinics that had at least 150 patients in the age range assigned to the MCO, and who also saw that the well-child rates needed improvement. So chose those clinics based on that criteria. A monetary incentive was provided to the clinic, and there were a variety of clinics that were chosen. 1 tribal clinic, 2 federally qualified health centers, and 2 private clinics. In this pilot, they focused on reconciliation, which is to find patients who had not had a well visit or were overdue for one, and to find patients registered to the clinic but just had never been seen. Next. Interventions for pilot 1 included focusing on patients that were overdue, ensuring the provider list of patients was reconciled, ensuring that providers knew who and how many patients they were responsible for, and helping clinic staff understand the performance measures related to infant and child health. A lot of interaction with MCO and clinics. Next. In pilot 1, lessons and observations, we found that it was difficult to match records. We found it was better to assign patients to a specific clinic rather than a specific provider. Patients don't always go to their assigned clinic is another observation, and we found that warm handoffs between MCOs and clinics were effective. Next slide. Other lessons are that patients receive care, but they didn't always return for their well-child exams. It's better to schedule the next appointment at the time of check-in, and clinics added and dropped lists of patients to the panel each month. So those were the observations. Next. Here we see some of the positive outcomes of the pilot. 4 clinics improved their well child visit rates for 3 to 6-year-olds, and 2 clinics increased by at least 8%. Next. Parent focus groups are another aspect of the pilot. These groups were held to find out about barriers to care. Themes we heard from the parents included there was a perceived stigma of having Medicaid. Work and school schedules didn't allow for the appointment, didn't allow time for the appointment. Language and cultural differences made an impact. The appointments were too short, and hidden costs like transportation and childcare. Next. In response to this feedback, lessons learned included that it's helpful to give parents a checklist of the screening procedures. Offer for parents to ask questions before and in between visits. Train office staff on better communication about insurance status. Provide materials in language of choice, and add weekend or evening appointments. Next. All right, that's pilot 1. And the second pilot we did with the collaborative PIP focused on adolescent well child visits. The goals of pilot 2 included to reconcile the patient list, and it also had the clinics contact the patient twice. And if the clinics were unable to reach the patient, then the MCOs would attempt to contact them. That was pilot number 2. Next, pilot number 3. Through 2019, the primary goal was to spread the impact and share lessons learned from earlier pilots, built one from another. Building on lessons learned, this was the most successful of the pilots. In the clinics that participated in the pilot, we saw an almost 10% increase in well child visits. Next. Pilot 3 also started social media campaigns and offered trainings to clinics. Next. Pilot 4. This pilot focused on statewide children's health promotion initiative projects. It focused on children with chronic conditions, focused on more social media, and they worked on a common form for patients to request changing their PCP. Next. So those are the 4 pilot projects, and here you see the before and after results. They show the impact of the pilots, and the bottom line is that rates improved. Next. In 2020, we saw challenges related to the COVID pandemic. For example, in-person visits decreased. By the end of 2020, well child in-person visits, they started to pick back up. We had precautions in place such as separate times and waiting rooms for well children and sick children. But 2020 was a challenging year for this measure. Next. In 2020, the collaborative work group decided to focus on Spokane County, which is in the eastern part of our state. The work group partnered with Child Care Aware. That's a community organization. They have contacts in early learning and child care centers. And with them, they gave out more than 4,000 educational flyers to parents in at least 4 languages throughout the county. After this initiative, county well visit rates for all the age groups were more than 11% higher than the statewide combined rates. This was a very effective community-focused promotion that we did in 2020. Next. This table shows that the last 3 years and the trend of the W15, the well child measure for the first 15 months of life, and these measures, the measurement years, 2018, 19, and 20. The final rate that you see is 54.1, 54.05, the final HEDIS rate. This is estimated right now, and that's because this is the rate that was reported by each MCO, and we'll get the final audited results later. They haven't been released yet, and that will determine what the final rate is, but this gives us a ballpark of what to expect. Again, in this rate, we see the impacts of COVID. Next. This is an example of outreach materials. 2 other flyers were created for young child and middle child. They were translated into languages such as Spanish, Russian, Vietnamese, and distributed in the community. Next. This is an example of social media messages posted on Facebook in 2021. They focus on things like free health checkups, how to schedule an appointment, and information like that, focusing in social media platforms. Next. 2021 and beyond, where do we go from here? Well, analysis of 2020 results correlate with what we hear from providers. Starting in April of 2020, well-child visits for children and adolescents decreased dramatically. Even with telehealth appointments, there was still dramatic decrease. The data indicates that in 2020, we lost some of the gains that we made in preceding years. In all age groups, the decrease in rates of well-child visits was significant, and that's what we saw across the board. The Spring 2021 Clinic Project focuses on educating clinics about the change in children's well-child visit measures. In addition, this year, MCOs are doubling down, working with schools, childcare, Head Start, and parents statewide to promote well exams, continuing to reach out to clinics and working in the community to promote the well-child visits. There's lots of focus on making up the lost gains that we saw because of COVID in 2020. Next. What we learned through the collaborative well-child PIP is that it's possible to raise rates of well-child visits and immunizations. It's possible to do this by making sure providers know the population of patients they're responsible for, collaborating with different agencies, facilitating providers to learn from each other, outreaching to patients and their families in creative and ever-changing ways, really listening to them and responding to that feedback, and ongoing analysis to improve quality. We've seen that value-based purchasing, performance improvement projects, and specifically the collaborative PIP are all effective strategies to increase infant and child health through managed care. Next. Thank you. If you have questions, you're welcome to email me at the email address you see on the slide, glory.dole@hca.wa.gov. And if there's time, I can take questions now.
Gloria, I think we'll move on. We'll take questions at the end, and maybe we can move on now to Bill Golden from Arkansas. Thank you very much.
Good afternoon, and there we are. Thank you for joining us this afternoon. Looks like I'm unmuted. We can move on forward. Tell you a little story about what we've been doing in Arkansas. Arkansas Medicaid has been a PCCM for years, really not a managed care state, but that has given us a enormous claims warehouse. We've done electronic claims for many years, and we've been using it for quality improvement projects, data analysis, policy reform for good 20, 25 years. And I work with contractors and statisticians who are familiar with our data set over many years, so they know our idiosyncratic codes and how the data actually works. We were one of the first, we were in the only states for a while in the South that did Medicaid expansion with the private option. So that was, those patients went, mostly adults, to commercial payers. But we, and our children remained in the traditional Medicaid. We basically provide insurance for close to 65, 70% of children in the state. In about 2013, 2014, we did multi-payer payment reform with the other commercial payers. We did episodes of care. We had a CMMI implementation grant. We have a whole nother day, beer and peanuts, about episodes of care. But we launched a primary patient-centered medical home in 2014, which is really the crux of what we're going to talk about today. Next slide. You can see when we started the PCMH program in 2014, we had hoped to get 40–50% of eligible Medicaid patients, adults and kids, in the program. In our first year, we had close to 80% of eligible patients involved. And as time went along, we have maintained about 85% of eligible Medicaid clients in a patient-centered medical home, which now has 215 practices and almost 900 PCPs. These numbers continued into 2020. Patients are assigned to a PCMH. They have to get referrals and so forth to get care. So everyone knows their panels. The patients know their primary care location, and the doctors and clinics and nurse practitioners know who they are accountable for. Next slide. This is an old slide, but gives you a sense of how the program was established in 2014, which is interesting. We told folks that they would get an extra PMPM on top of their PCCM dollars, and we call that an investment in their practice, that it wasn't just new money to be in the program, but we expected them to do things in exchange. We also set up some bonus money so that if they performed well in terms of total cost of care, which we no longer use, we now do different incentive plans, they could get substantial bonus checks. But the key thing was in the beginning, the PMPMs were tied to certain performance activities that they had to achieve to get the dollars. Next slide. So what kind of things did they do? Well, we told them they had to have an EMR. They had to have 24/7 live voice access to their care. I jokingly tell people that if I retire tomorrow, I can put on my CV that I eliminated answering machines in rural Arkansas in a period of 2 years, which was a much greater lift than one might think at the time. But we also had them designate high priority beneficiaries, a whole variety of patient-centeredness in order to be a PCMH. But now that the program is well established, these activities that they had to achieve to get the PMPMs and keep them are basically baked into the system and are now basically part of the routine. Next slide. Which gets into how we're now using measures. Obviously, we want to use the measures. We have to have effective analytics. We want to drive culture change, particularly how to use data and how to transform clinical activities. We are now using these measures tied to incentives, and the incentives are connected in 3 different buckets, if you will. The first incentive was for excellent performance. And in the beginning, as I said, it was for total cost of care, but now it's to other performance metrics, emergency room utilization, hospitalization rates, and we actually now have a bonus plan for adolescent wellness visits, because that straddles adult and pediatric care. The second bucket, or the second use of the measures, is what we call achieving average performance, and that we call a toll booth. These are quality measures that basically look at state average performance from a previous year. And the practices, or the PCMHs, have to achieve average performance for that past year in order to qualify to be considered for the excellent performance bonus money. So there's no direct dollars involved with achieving these toll booth measures, but they basically qualify people to be eligible for the big dollar bonus money. Then in the last 2 or 3 years, we took on something that we were kind of hesitant to do. We actually started to set minimum performance measures, which is to say that now that they were established and achieved their medical homeness, if you will, their patient-centered attributes, we threatened to take away the PMPM dollars if they didn't achieve some minimal clinical performance. And when I mean minimal, I really mean going after the low performers or the folks who are outliers compared to the average PCMH. And we'll show you what the impact was on implementing this change. Next slide. So here's an example of the bonus money dollars. This is for emergency room utilization. And you can see the upper 10% get the big dollars, then the upper 35% get some other dollars. And basically, we set this from year to year on a normative basis. Next slide. Next slide, please. Oh, we're stuck. Oops. Let's see where we are here. Okay, so, nope, go back one slide, please. Thank you, there we go. So this, nope, one more slide back, sorry. There we go, thank you. So this is the performance for calendar year 17 for well-child infant visits. And we were targeting at that time 5 or more visits. Now, I understand that's not the national standard is 6, but our performance was sufficiently problematic. We were trying to target something that we could see on people's horizons. And you can see that only 62% of PCMHs achieved the 63% achieved 5 or more visits. We had this long tail. And this was pretty static. We actually did academic visits, academic detailing. We had a NASHP academic program 10 years earlier. And I have to tell you, but this 5 or more visit curve really didn't change much over the years. So next slide, we decided to look at the laggards. And here were people who were doing 0 or 1 well-child visit in the course of a year. I mean, really low rates of performance. And we had 5 PCMHs, you can see here, that had 20% of their infants with 0 or 1 well-child visit in the calendar year 2017. So we said, okay, folks, and we basically said, if you can't get above 20%, 0 or 1, we will very likely take away your PMPMs, your basic core support money for being a medical home. So you basically need to do better in order to be considered a medical home for the dollars. And not only are we targeting these low folks, but we set the rest of the curve on notice that we're going to start looking at low performance. What happened? Well, next slide. In 2018, all of a sudden, we had 9 that were above 15%. So we moved the curve. You can see the curve began moving starkly to the left. We started getting rid of the outliers. So we said, okay, for calendar year 20, you have to have less than 15% of your infants have 0 or 1 visit. Next slide. And in calendar year 19, 1 PCMH had more than 12%, 0 or 1. That's quite a change over a period of 2 years. So what happened to the other measure? Next slide. This is where it gets interesting. In 2017, here's the static slide. 23 medical homes had fewer than 50%, had fewer than 50% of their children have 5 or more visits. Next slide. A year later, 9 had fewer than 50% of 5 or more visits. And you can see that the average for the state went from 63% to 69%. And next year, next slide. 2019, 5 PCMHs had less than 50% well-child visits 5 or more, and the state average hits now at 75%, which means we moved the state average 5 or more visits about 20% in 2 years. And the only major change we had in the operations was to go after the laggards and threaten their PMPMs. Now, I will say, just like what happened in Washington State, 2020 was disruptive, and we did have backsliding in our well-child visits. I will say that it's interesting that the infant visits and infant immunizations took less of a hit than the 3 to 5 visits and the adolescent visits. And indeed, when you look at overall utilization, parents were bringing in infants, but acute care visits for colds, ER visits, asthma, etc., for 3 to 5-year-olds went down across the board. The good news is our immunization rates did not suffer terribly in infants. We did better on measles shots than we expected. The older child booster measles vaccine was much more problematic. Because of this improvement in these numbers for 2022, we're going to now set the standard. Instead of having 5 or more visits, we're making it 6, and we're moving the target lower to give them credit for the fact that we are now adding another visit for expectation. And for our laggard target, we're going to make it 0 or 2 visits to be at risk for losing PMPMs. Next slide. So what's some of the lessons here? Well, you could say that this actually follows behavioral economics, where very often the risk of a loss has more impact than the value of a small gain. And I think we've seen that threatening people with a loss of something they had changed behavior much more dramatically than the potential for being part of a small gain. Next slide. So, this is how our philosophy of the PCMH program. This is just one piece of how we use measures and try to improve care. But we basically have set programs and measures in place and measurement, which stretch the providers who provide program feedback, which modify requirements and analytics. By the way, all of these practices now have a very substantial practice report card that gets updated monthly, and many of them use this as a game changer to drive their own practice management style, and their practice managers use this report card on a regular basis. We then support practice transformation. We then push the practices a bit more, and we have a whole new cycle of dialogue to how to improve care and make sure our data analytics are appropriate and are supportive and achieving and pushing for achievable goals and implementation. So here's my email if you have questions. And again, thank you for listening. And I hope this is useful for your program.
Thank you, Dr. Golden. Okay, so we are now going to open it up to questions. And just as a reminder, next slide. This is how you submit a question. You put it into the Q&A and select all panelists in the Ask menu. Type your question, and it will come up in my little Q&A box, and I will read it aloud. And so while people are doing that, I will start with a couple of questions that are already in the queue. So the first one is to Dr. Golden. How big are the bonus or incentives that doctors get? And as a follow-up, do PAs or nurse practitioners get bonuses as well?
The bonus dollars in the beginning were a percentage of the shared savings, which that's a whole other discussion about the complexity of maintaining that kind of a total cost of care program. So we have moved away from that. But essentially, there is about a $12 to $13 million pool, which is split upon those 3 or 4 measures that we have, which we call focus measures. And the top 10% get the biggest share of that dollars, and then the top 35% get a smaller share. So it is a $12, $13 million pool, so the checks can get pretty substantial on a per member basis, depending on the size of the practice. At this time, PAs and nurse practitioners are not eligible to be PCPs in our program. That'll change in 2022. However, I will say that the practices that have gotten some of these big checks have been very creative in how the dollars are spread around. And in fact, we heard stories that some practices gave bonus checks to front desk clerks who were absolutely shocked because that their doctors and practices gave them the extra money, but they were told by their practices that they were essential components of reaching out to patients, getting patients to understand the system, and engaging patients in becoming a part of a patient-centered program. So every practice can do their own thing, but in very many of these practices, it's considered a team effort. Jobs have been redesigned, nurses and PAs have been re-empowered, and dollars have been shared across all elements of the team.
Great, thank you. Okay, the next question is for Glory. So Glory, some of the particular pilots in the PIPs focused on older children or toddlers. What lessons learned from those PIPs would you change or would you test specifically for the 0 to 15 month infants? And what might you test that might be new?
Oh, thank you for that question. Yeah, I think one of the most effective things that we saw were really the engagement with the clinics, the engagement with parents, training, education, and those kinds of things. I think that can be, we saw effective change, you know, across the age groups with those lessons learned. We actually have fairly good infant rates, and we have been concentrating on the 3 to 11-year-olds because that's where we see a great need. The prenatal and postpartum BBP should have a positive impact on infant rates as well. That was one additional thing that we did this year. And so those are some of the efforts and focus and lessons learned that we've had through the pilot projects and through the other PIPs and things that we can focus in the future.
Great. Okay, so this question is actually for both of you, but let me start with you, Glory. And so in what ways, if at all, are you tracking disparities and implementing efforts to push plans to close racial and ethnic disparities? Why don't I start with you, Glory, and then I'll ask Bill you to respond to the same question.
Thank you, and I really appreciate that question. One of the things that the Healthcare Authority has done in the past year is we actually hired a health equity person to coordinate all of the health equity activities that the agency is doing and have a coordinated strategy that really focuses on health equity, diversity, equity, and inclusion. There are lots of different activities across the agency, and this person is able to get us focused, get a strategy around it, and see where we need to go in the future. Been able to implement just within the agency already a focused website that is in alignment with the Office of Equity and Inclusion that our governor has put in place this year, and we're able to do a lot of internal training. We are able to get this focus, health equity focus, in our interactions and meetings and contracts with the managed care organizations. The annual report that we put out every year that demonstrates and shows the how well the MCOs and managed care organizations are doing in terms of their performance. There is a big effort to include social determinants of health, racial and ethnic disparities, and getting better data around that. We have implemented several work groups to try to understand this better. In Washington, we see that our the data is, we have problems with it because of very low numerator denominator issues where the pool is just not very large. And so getting better data having better focus on how, we need better data, how do we get it, and having really focused work groups on that. We are working directly with our external quality review organization for them to research what best practices other states are doing around getting better data around these disparities. And it's a constant part and integration of our system. One thing that I would like to highlight as well from Washington State is we're putting health equity focus into all of our job descriptions this year during our annual evaluation period. We're rewriting every single job description to include an integration of health equity focus into every person who's employed at the Healthcare Authority. So there are tons of efforts and things that the state is doing around health equity, and not just around infants and children, but I think that the global efforts definitely impact this specific area as well. So those are the things that I would say about health equity and what we're doing there.
Great, thank you, Glory. And can I pose the same question to you, Dr. Golden? Yeah.
And I'll tell you kind of an apocryphal story. 10 years ago or so, someone from AHRQ gave me a call and said, gee, we have an annual quality report, we have an annual disparity report. You guys look great in terms of disparities in X, Y, and Z. And I said, well, yes and no. And he said, what do you mean? I said, well, the reason why our disparity looks so good and our lack of disparities is that because the white population gets equally bad care. And we are way below average. So we have equal opportunities for questionable care sometimes in terms of care gaps. So, it is interesting how it gets spotty, and we do get some data, we do run it, and it really is variable. We just did some data analysis on our expansion population, and white women are getting less breast and cervical cancer screening than Black women. Black patients are getting less substance treatments than white patients. It really is variable depending on the topic. And so we are working on them on a per topic basis, but also many of the other issues that come across in terms of disparities get into many of the social functions of the Department of Human Services, well beyond just the clinical provisions of care. I will say, though, that in terms of clinical disparities, it's not quite as obvious, perhaps, than in some regions, but we are working in care gaps throughout the system, and very often they are equal opportunity care gaps.
Okay. Let's see, lots of questions here. Let me ask you, Bill, about what are some of the activities that you've heard from the providers about what has been effective for them to improve the number of well-child visits for this population?
Yeah, obviously, medical homes here, we've been going on now 8 or 9 years. We were a CPC state, a CPC plus state. There have been webinars, there have been coaching teams, there have been regional meetings, regional group sharing. It's really become a community of primary care, patient-centered medical home entities, and they have been freely sharing with each other and presenting to each other. So it's really been quite a transformation in the state, and I think the culture of primary care has been massively improved by being part of CPC Plus, CPC, and Medicaid and commercial medical home programs.
Great. And I think a follow-on question is, what processes do you have to involve the practicing community in setting the performance expectations?
Yes, when we put the minimum performance in, we had a legislative mandated advisory group come in, and they're kind of the squeaky wheels of the practicing community, if you will, and we outlined for them with a little bit of trepidation that we could threaten to take away PMPMs for minimum performance. And they looked at our numbers, we looked at what we were targeting, and they looked at us and said, well, you know, if those folks in those outlier status numbers can't do better than that, they shouldn't be in the program. So these folks were actually saying, hey, we're doing the work. We should expect people to get with the team and do something to earn their dollars. We also we just had a webinar today outlining next year's metrics. And we also have a regular advisory group, which we call the Strategic Advisory Panel, that meets Wednesday mornings, 7:30 in the morning. We meet about every other month. There's about 80 people on the call, but about 15 people are the designated advisors. And that's where we suggest new ideas. They are able to raise issues and problems and questions about our data. Excuse me, someone wants to sell me insurance here. It actually is a good dialogue and keeps everybody in the loop, both about problems in the program as well as potential new opportunities for changing the program for the better.
Great. Okay, and a question for Glory. This is coming back to your engagement of parents, and somebody wanted to know how you engage parents for the focus groups.
Oh, you know, that's a great question. And I saw that in the chat and I reached out to folks who had been involved with this for years. And that was, we actually will need to get back to you on those details. We know there were a lot of really great community outreaches with the Department of Health and the MCOs. The specifics of exactly how they reached out, you know, did they call them? Did they cold call them? Were there folks provided to them through the clinics? I don't exactly know the specific details of how they got that group together, but what we do know is that, you know, the focus, the question, there was really great qualitative, you know, asking questions and really great listening, and that to me was the real take home point. The logistics of how they got the group, we'll definitely have to follow up on those details. I don't actually know.
Okay. Okay. This is again a question for Bill. Let's see here. I think this question is getting to sort of the process for making this all come together. And was there a contract amendment? What was the prep time for making the threat a real option? Can you just sort of talk a little bit more about sort of the process that helped you get there?
Sure.
And how, you know, how others can copy it or adapt.
Started telegraphing it about 6 months before it went into effect, before the year of measurement went into effect. We let people know they were outliers. We tell people also, this goes back to failure to, and remember that first slide about things they had to do to get the PMPMs, like have an EMR or get rid of answering machines. If they didn't achieve those elements, we threatened to take the money away, and we gave them 6 months to remediate. And believe it or not, we did take away money. We just said, you know, this is a program, it's voluntary, you don't have to be in it. You're not kicked out of Medicaid, but you know, you're not meeting the expectations of the program. And we're doing that with now these performance measures. If you fail a measure, we send you a notice saying we need a corrective action plan. We expect these numbers to get better. If we don't get the corrective action plan, we'll stop the payments. And if you don't achieve your numbers, we'll stop the payments. They're allowed to appeal and appeal their data. So there's all sorts of safeguards. But yes, people do actually lose their dollars. And very often it's practices that really just can't get their acts together.
Okay, so I think I only have time for one more question. I'm going to make it for you, Bill, and this is sort of a two-parter. It's about how the physician community has responded to the accountability measures, and in particular, there's a question about whether there has been any sort of discussion or suggestion to risk adjust some of the thresholds and targets for minimal performance?
The bonus money dollars, the normative stuff, is risk adjusted. And, we will let people take 1 or 2 patients out of their pool for measurement. We do work with each practice in terms of if they want to appeal their numbers and why they had issues. So a lot of it is tailor-made. There's an open dialogue. We want to make the program as fair as possible. The fact that I think I showed you the first or second slide, enrollment has been robust and remains robust. The primary care community has been strongly supportive of the program. They much prefer this over dealing with a managed care program. They had told their legislatures they like the PCMH program. And so it has, as I said, been transformative. And we try to maintain an open dialogue, and we do respond to comments and questions. And, sometimes when people raise complaints and questions, they're right. They actually point things out that are problems with the system or problems in their local environments. And we work with them to try to overcome and to remedy those issues. So we have learned about local systems issues that we wouldn't have learned about otherwise. So we try to make this a collaborative process. And I think the practicing community has been very appreciative of this engagement and this responsiveness. So like, for example, with COVID, we rapidly implemented changes to the program to allow telehealth visits. And that quick responsiveness actually helped keep many of these practices alive during some of the lean months in the early phase of the COVID epidemic.
Great. Okay, well, this has been a fantastic conversation. We only have a couple minutes left, and we do have a couple of announcements and next steps. So I'm going to first thank the presenters, but then turn it over to Alyssa. Alyssa?
Great, thank you, Jody. Next slide, please. So in closing, I'd just like to again remind everyone to visit the Medicaid.gov Infant Well Child Care landing page, which is displayed on this slide. And you also have it in the chat for more information about the Learning Collaborative's upcoming webinars and affinity group. Next slide. Again, as I mentioned, you'll find a transcript and recording from this webinar and the first webinar in our series on the page, as well as information and registration links for our upcoming webinars, which are all listed here. And you can access more information about the upcoming affinity group here, including the affinity group fact sheet and expression of interest form. If you're a state Medicaid agency interested in participating in the affinity group, you should complete an expression of interest form by September 30th at 8 p.m. Eastern Time. Next slide. And finally, just wanted to say thank you all for attending. And as you exit the webinar, please remember to complete the evaluation, which should show up for you in a separate browser. If you have any questions or if we didn't get time to answer your question today, please email us at macqualityimprovement@mathematica-mpr.com. So thanks again for your time and have a great afternoon, everyone.
Thank you.